So I really want to thank you, Regine, for being a friend, but also for the introduction. And most importantly, for all of you, for having me in this series, because this is, for me, one of the most important talks I give. And it's really interesting that it comes in Cancer Day in the world, because I do think for these specific syndromes, actually, your area is the area that it's most common, most impactful, and actually least aware. And just to understand, to fight cancer, the best way is not fancy targeted therapies, but cancer prevention, which we are doing very little in the world, isn't it? To do prevention, you need to do early diagnosis, which we are doing, I'll show you. And before that, you need to have awareness. You need to diagnose these individuals and these cancers, which we don't do a good job all around the world. So I hope this talk will raise the awareness to treat replication repair deficiency, and I'll explain what I mean. It's 40% awareness, 40% adherence to protocols, which I'll talk about, and we do that really well together, and only 20% the fancy therapies, which I'll talk about that too. The last thing I want to do as an introduction, you see on the right upper side, the sign of yin and yang. I think that's really important. So I'm a pediatric oncologist. I can tell you several things which I call the tip of the iceberg. First, it's not a pediatric story. At least until age 40, we see all these stories. So if some of you are adult oncologists, we are missing patients from 20 to 40 because we are not aware of. Second, the beauty here is that you can learn from just looking at the tumors about which patients have cancer predisposition, but also we can learn from cancer predisposition how to treat tumors. So there's a yin and yang, which I'll focus about today. And I'll tell you a story that changed my life. And I was just a regular pediatric oncologist until roughly 2007. And at that time, Dr. Eric Buffet, that most of you know really well, is my mentor and colleague and friend, is leading an international work group that we are actually having monthly teleconferences with Jordan, Pakistan, and other countries. And within these rounds, we saw these weird children that are supposed to be NF1, but they are dying very rapidly. So to tackle that, we now have a team of gastroenterologists, Carol Durno, a genetic counselor. She's the world expert on this, which I'll explain now. And these are the cases. They look like NF1. You see they have cafe au lait spots, but instead of having low-grade gliomas and plexiform neurofibroma, they can be looking completely like NF1, fulfill the criteria, but they usually don't have the learning difficulties, the short stature. They have family history of cancer sometimes. They have normal growth, and they have consanguinity, and they die very rapidly from malignant tumors. Initially, we thought it's leukemia and lymphoma and brain tumors, but now we know it's not true. So a little bit of biology, don't worry, it's not going to be too much. But here is the story. These patients are actually having mutations in the 4 mismatch repair genes, MSH2, MLH1, MSH6, and PMS2 in their germline. If you are heterozygous, so one of the parental allele from the father, for example, is mutated and from the mother is normal, you will get what you see in adult, colon cancer and genitourinary cancer when you're 50. But if you're biallelic, and that's why it's very impactful in your area because of consanguinity, you actually get the most aggressive cancer syndrome in human. And you'll see later, you have about 50% chance of having multiple cancers in childhood, not only one. Everybody is affected, and almost nobody reach age 18. At that time, we thought it's mainly brain tumors, gastrointestinal cancers, and leukemias and lymphomas. But as you can see, it's not true. The biology is so simple that it's okay to mention that. So when a cell wants to divide, it just needs to replicate the DNA, to have 2 copies from one. And that's done only by one enzyme called DNA polymerase that replicates the DNA. In each time that it replicates the DNA, it creates millions of mistakes. Not one, millions. Most pediatric cancers have one mutation. In these normal cells, they create millions of mistakes each time the cell divides. But in the DNA polymerase, there is an area that's called a proofreading domain that fixes some of these, and most of these are repaired by the mismatch repair genes. So you understand now that if these don't work, or the polymerase doesn't work, you get crazy amount of mutations. You also get something which is called microsatellite instability, which I'll explain later because clinically it's important, and you get cancer at very young age. So to tackle that, now we have an international consortium, and you can see Regine and other people in this. I think this is Regine and other people here in this international workshop that we did, and we are planning the second one, which now have more than 45 countries. Many of you are involved, and we offer free surveillance, free genetic testing, free counseling, and free management of patients together, including we're able to get drugs to several countries. And I think please join the consortium. It's highly important for everybody. So here's the beginning. This is actually a Palestinian doctor, Dua Bakri, who started looking at these patients with us. And at that time, we have only 25 patients, just to understand. Now we have more than 200. And what she found was something very striking. You see how many tumors? 24 patients develop 42 tumors. It never happens in other syndromes. Interestingly enough, which is very common in your area, because of the mutations, some of them are called hypomorph, then the family members will not always have history of cancer. So it's confusing with respect to genetics. And the Lynch syndrome I'll talk about later. We were able then to actually sequence these tumors. And sequencing means that you just look for mutation throughout the genome. And here is called, it's called mutations per megabase of genome. And in the y-axis, it's 1, 10, 100. And here is all cancers in children and adults. And usually, as I told you, in children, you have less than 1 mutation per megabase in all childhood cancer. Our tumors had not twice, not 3 times, but 1,000 times more mutations. It's really, really important because it puts them in a different level. It's actually higher than all adult cancers, including ones who respond to immunotherapy like melanoma, which are here. So the highest ever seen in humans. It's actually very interesting because what they do, if the tumor, because of the germline mutation, is mismatch repair deficient, it gets a secondary mutation only in the tumor of DNA polymerase, which I told you before. So then it's combined replication repair. And then within 4 months, you get 20,000 mutations in the same tumor. Here, a tumor relapsed. But a clue that it may be good for us is that when the tumor relapsed again, it didn't go to 40,000 mutations. It stayed in the same, meaning that the tumors are maybe not very efficient, which is really good for us. So now the first part of the tip of the iceberg to tell you what we know today, 15 years after. I think we understand that we need diagnosis and awareness. I'll talk about it. I'll talk about early detection. I'll talk about biologically rational therapy and a little bit about prevention. But it's not only CMMRD. CMMRD when you have both genes unaffected, but actually many cancers in age less than 40, in brain, sarcomas and otherwise, we just didn't diagnose it, but originate from Lynch, from the patients who are heterozygous. And you can have a germline, not in the tumor, mutation in DNA polymerase, and you get multiple tumors too. We are completely unaware of these and we miss them. For example, is a beautiful story that was done by Nisreen Amariri from Jordan. And she looked together with her pathologist on the 10 years of glioblastoma and gliomas in Jordan. And she found that actually 50% of glioblastoma in children are actually mismatch repair deficient. So half of the glioblastomas in Jordan are because of what we are talking about, which is a huge, huge impact. And we just miss them because we never look for them. Okay, so first, now let's say that we want to be aware of that. And we know to look for cafe au lait spots and family history of consanguinity and all of that. We need to have that. If it doesn't, we don't do that, we'll never find it. Which diagnostic tools we can use? So actually the common diagnostic tools until recently were one, genetic testing. It's very expensive. And about 30%, a third of cases, we don't get the right mutation due to many reasons. Second is an assay called microsatellite instability. I'll explain later. Don't use this assay. It's terrible. It's built for colon cancers in adults, and it doesn't work in children. 18% sensitivity. But a very simple assay that we can use all over the world is just simple immunohistochemistry. And here I'll show you an example. Look here. This is a tumor. Again, you can learn from the tumor on the germline. This is a tumor that we stained for the 3 mismatch repair genes. You can see that it's positive brown in 3 of them, and it's negative in PMS2. But it's not only negative in the tumor cells, it's also negative in the blood cells and the lymphocytes there. Means that it's not only in the tumor, it's also in the germline. And actually, we know today that it's about not 96, it's actually 92% sensitive. So it's a very good tool to start with. And again, microsatellite instability is terrible. I'll talk about it later. This is a case from Lebanon. Then until today, 15 years after a patient of Rula Farah, actually we diagnosed the family, but we don't know the specific mutation in the gene because it's impossible. But simple immunohistochemistry done on skin biopsy diagnosed the family, and one of the kids is still alive. So look, the father has normal stain in the skin. The mother has normal stain. 3 of the brothers are brown here, which is normal stain, 4. But the index patient who died actually have negative, this is normal tissue, negative skin, and also the sister has negative, and she had a brain tumor and she's still alive. So early detection is simple, can be done on simple assays everywhere in the world. But now I'll tell you about the new tools that we have. And to do that, we actually worked with an organization called Foundation Medicine. We looked at over 80,000 tumors, and we wanted to see if sequencing can help us. So the first thing, if you look at all 80,000 tumors, this is again mutations per megabase. Remember, you can see that most tumors will not have hypermutations, but once you get to 10 mutations per megabase, there is a huge acceleration of the mutations, and more than 10 mutations per megabase is called today hypermutant, and about a third of them are mismatch repair deficient. But if you're ultra hypermutant, more than 100 mutations per megabase, then all tumors are because of our syndrome or our replication repair deficiency. So this is a tool that becomes 100% specific when you get to higher mutations. This is in children. As you can see, it's more rare. It's about 5 to 10%. But look how many tumors we are missing. So we knew about glioma, we knew about lymphoma, but what about Ewing sarcoma? What about neuroblastoma? What about Wilms? We have patients that we just miss them because we do the wrong assays. So again, if you have a family which you think may be important, just do the immunohistochemistry, and then you'll find that it's mismatch repair deficient. And these tumors are completely resistant to chemotherapy. These patients usually die. More interesting thing to do, and I'm sorry I'm complicating life, but it will get to you, so it's better to just get used to that. So instead of looking for mutation in a gene P53 or BRAF, or like in V600E in LCH that you just talked about, here we're just looking at the whole genome and seeing if the mutation is, no matter where, is a C2A. So a C2A can be because of tobacco use, very common in lung cancer. A C2T can be because of exposure to light in melanoma, but there are also specific, and that's millions of these in the genome, but you can also have specific signatures which are mismatch repair deficient, meaning, hey, look for our syndrome, or DNA polymerase. So when we screened 80,000 tumors in adults, you can cluster them no matter where they come from, no matter who they are, just on base of these signatures. And I'll focus on 3 here. Signature 1 is our patients. They have germline mismatch repair deficiency. It's an early mutation that causes this signature, and sometimes secondary DNA polymerase in the tumor. This is the Lynch patient, remember? Patients who have mismatch repair alone, and they're older, mostly colon cancer, but you can find sarcomas here and brain tumors. And here is cluster 3, which have polymerase as the germline mutation, as the first mutation. And all of these, we were never aware of them. So what we did, which is very cool, I think, we actually, this is patient from Foundation Medicine. Nobody knows about them. The doctor gets a report which doesn't have, at that time, the tumor mutational burden. So we looked at several algorithms, and then we called the family and we called the doctor and the family and said, can you do genetic testing to see if actually the
Oh,
tumor
sarà
is
l'amministrazione
ready
che ho
for
avuto qua.
mismatch repair? And if
Ehi,
it
ciao.
is, we can initiate surveillance or therapy. So out of 19 patients we called, all the ones who had signatures, so we didn't know anything. This is just tumor sequencing, no germline. All of them stem from germline mismatch repair in blue or polymerase in orange. All of them were put on surveillance, which I'll show you soon, and many of them are on immunotherapy, which I'll talk about. So that is an old tool. I have a better tool. So microsatellites, which I told you it's a bad tool, and I'll show you, are actually repeated sequencing in the genome. So for example, here you can see 10 A's. So the 10 A's can be in the next cell, become 9 or 8, or can stay 10, or can be 12 or 13. If they're changing their size, so the multiple A's become longer or shorter, it's called microsatellite instability. And in many years, there was a tool called microsatellite instability, which looked at 5 locations in the genome. Okay, so when we tested our patients and tumor, remember, our patients have no mismatch repair deficiency in their normal cells, but they never had microsatellite instability looking at 5 sites in the genome. And even in cancers, it was 10% specific, 30%, very, very low sensitivity and specificity for sure of the assay. So something is wrong. So what we did, we looked at our tumors, and now we looked at the whole exome and the whole genome. Just to explain, in the genome, we have 20 million microsatellites. And then everything is very clear. You can see here, this is multiple childhood cancers which are mismatch repair proficient, so have no mismatch repair. And this is our tumors. You can see the p-value that you never see with any testing. And that is actually as good for adult cancers and in children. I'll skip this one, but actually remember the signatures that I told you? This is not random. If you have mismatch repair deficiency, here you can see if it goes here, it's a deletion. It goes from 10 to 8 to 9, or from 50 to 49. And if it goes up, it's an insertion. And this is the size of the microsatellites. And you can see very nicely that if you have mismatch repair deficiency, such as CMRD, you get deletions. So it's not random, it's specific for deletions. And if you have polymerase, you get insertions. You have additions of bases, not deletions. So now you can have this beautiful diagnostic tool. And here is the story here. Look, this is so interesting. This is all our tumors at that time, which we can stratify them into mismatch repairness, poly-ness, or nothing. So the green are the usual tumors sequenced in our institutions. The ones in red are mismatch repair only. The one in blue is a polymerase tumor only. And all of these are brain tumors, which are mismatch repair plus polymerase. And it's so good that even our sequencing center made mistakes in 4 patients here. You see, we called them mismatch repair deficient, but they didn't. When we went back to the family, they were all Lynch or CMRD. So this is a diagnostic tool that we can do today, not only on tumors, we can do it on germline. And this is a tool we developed and we want to excite you, which is very cheap because we used low coverage genome, it's called. And this is blood test to look for CMRD, even if we can't find the mutation. And you can see how good it is with respect to all the controls. If you have NF1, leaf-rho many, other mismatch repair deficiencies, or normal, this is an amazing tool to call mismatch repair deficiency in normal tissue. This tool is better than all the other tools that we discussed before. It's actually very cheap and very rapid, and we'll try to implement it clinically as soon as we can. Through the consortium, this is how we diagnose today mismatch repair deficiency. Okay, I just want to summarize until now that you can use mutations to be diagnostic tool, not only the old tools of immunohistochemistry and other things. You can use the tumors alone. If you just get the block and you send it, we can do what we call reverse genetics and tell you this patient is germline mutation, this is not. And the microsatellite instability is a new tool that we are very excited about. Now, this is for me the most important part of the talk because we need to implement that. And this is recently accepted for publication in JCO. So can we do early detection on these patients? We wrote this surveillance suggestion, meaning early detection, which is very cumbersome, about in 2008. And since then, every patient in the consortium, we offered them that. Many of them did it and many did not. And actually, surprisingly, in nothing to do with developing countries. They didn't do it because the Americans didn't believe in that. So here is the data. First, to see if our tools capture everything, what we found, and now we have data on 570 tumors, and this is our cohort, and this is the other European and other papers, literature cohorts. You can see that although brain tumors are the most common, followed by GI cancers and lymphoma leukemias, by the way, all types, including AML, we have tons of tumors which are not the regular tumors. So most pediatric cancers, but actually once you reach 20, between 20 and 30, many will get breast cancer. We have patients 30 years old with prostate cancer. So this is how we need a total body MRI, because we cannot just detect it by brain MRI and a scope. And this is just to tell you stories. This is my patient, actually. She had a total body MRI that found a dot. This is a glioblastoma 12 years ago, and she is now alive. She had 5 cancers, including breast cancer, but she just finished university in Toronto, and she's a very good advocate for us. So 15 brain tumors, I'll show you, were detected. But when you do a scope, all the patients that had scopes, 24 patients developed 21 colon cancers. Everybody has polyposis, but 24 of them, all the 24 are alive. This is amazing work done by Carol Durno, the gastroenterologist. But now when we summarize about 200 tumors, as I told you, you can see that for tumor, you can have surveillance is much better than when you are symptomatic. So this is per tumor. Tumors which are asymptomatic had better survival than symptomatic tumors. It's very cool because this is glioma only. And in glioma, we don't think that resection has any role, but look at that. If the tumor is small enough and you can take it out, you have better survival. Interestingly, in brain tumors, when we look at all patients who had surveillance, you can see that 2/3 we found asymptomatic, and the one that we found symptomatic were always the one that we did scans after a year and a half, or after, or not on time, or did the wrong scans. Everybody that fulfilled the protocol were asymptomatic. All our tumors in the gastrointestinal tract were found asymptomatic. Nobody was symptomatic. But in leukemia lymphoma, we were not good. Most of the leukemia lymphoma were found symptomatically, and we need better tools to deal with these group of patients. But the most important thing is this. When we looked at just survival of these patients, you can see that patients who did not have surveillance, almost all of them die within 8 to 10 years because of multiple cancers. Patients who are partial surveillance, that's the cool thing. Patients in developing countries who could not have a total body MRI still had superior survival. And I think that is something, Regine, we need to develop really well together with cheap diagnostic tools. There's a lot to do, even if you can't do all the assays. So for me, that's the most important thing. Just to explain that if you do an MRI or a colonoscopy and you find a low-grade lesion, like a low-grade glioma or a polyp, please take it out, because 100% of these transform to high-grade tumors, and we don't want to wait for that. So in Lee-Romani, my colleague David Malkin, I think he should give a talk, I hope. Actually, only 50% in 10 years will progress from low-grade to high-grade, but here it's 100%, usually very rapidly. So please, when you get something, take it out. But remember, I showed you about this cheap assay that we developed? We also had within this group, this is the highest mismatch repair, but we had some mismatch repair patients which were actually lower, still much higher than the normal. We call them atypical. This is not a random number. These patients actually developed cancer only at age 20 and after. So now I can say, if we have the functional assay and you are here, we can say you don't need to start surveillance at age 2. You can wait for age 15 to 20 to start surveillance. So this is why these tools are so important. So the last and not least, I hope I have enough time, Regine, is to excite you about these new therapies that we have. And I think it's important. Some of them are available in everywhere, some are not, and we can help, but it tells you about the potential of the diagnosis and awareness. So this started by us, by looking at, remember the figure that I showed you? Our tumors here are higher than melanoma, lung, bladder cancers, and mismatch repair adult cancer. And that's because they're actually, and these tumors are responding to immunotherapy, isn't it? These tumors, you give them immune checkpoint inhibitors, they're doing well. And again, we do not diagnose all the ones in orange and red here. So it may be much more common than we think. For example, we had a Wilms tumor, which responded to immunotherapy. We just never diagnosed them. So Eric Buffet, as I told you, my mentor and friend and colleague, treated bravely 2 brother and sister from Canada, which had relapsed glioblastoma. This sister actually had metastatic disease, was sent home to die. And when we called her back, look at the responses that she had everywhere. And she lived a year later, going back to school and normal life. Her brother actually had complete disappearance of the tumor, and he lived several years after without any evidence of disease. In this patient, after we stopped immunotherapy, which I'll talk about, he had a new tumor, and I don't know what does it mean. Again, tip of the iceberg, we don't know yet. But now we have data on 45 tumors. And look at this survival post-relapse for malignant tumors. This is the survival for these tumors without immunotherapy. Nobody is alive at 2-3 years. And here we have almost 50% survival. It's not only survival, and I'll show you that. This is called waterfall plot. If the tumor responds, it goes down. If the tumor progresses, it goes up, okay? Look, these responses in blue in glioblastoma. I have never seen any glioblastoma respond that well to any kind of therapy upfront or at relapse. So these are dramatic responses which you have never seen before. I'll skip that flare because we don't have time. But this is called swimmer's plot. So this patient is swimming for 2 months. This patient is swimming for 4 years. And actually look at this patient. It has 2 tumors which both responded to immunotherapy at the same time. So you see that many patients here are still alive and still on or off therapy post-immunotherapy. It's not random again. We know why some tumors respond. The ones who are blue are mismatch repair deficient. The ones who are orange, this is called oncoplot, are mismatch repair and polymerase. And you can see that the ones who are together, complete replication repair deficiency, have higher mutations. And this is affecting response to immunotherapy. So higher mutation results in higher PD-L1 that you can do in your institutions, isn't it? Higher CD8 in brain tumors, which we never see. And together, hypermutation and immune function can give you 80% or 90% survival in these patients. So it's a very good predictor of response to single agent immunotherapy. As I told you, this is about 110 of our patients, and many die in the first cancer here. Some we follow and never developed a second cancer, but as you can see, most who survived one will get another one, which is called metachronous. And some, about 25%, 1 in 4, will develop 2 cancers at the same time, which we can never treat with chemotherapy. When you have a colon cancer and lymphoma, you don't know what to do. But all of them, each one is a patient that had 1, 2, or 3 tumors at the same time. All of them are hypermutant, suggesting that maybe we can switch from chemo to give them immunotherapy. And this is a great story from Australia. Again, a patient that was sent home to die because it had metastatic colon cancer. So they didn't touch the colon because it was metastatic to the bone, and a brain tumor at the same time. Sent home to die. We called him started immunotherapy, and in 3 months, you can see disappearance of the bony mets and bone renovation. But remember, we didn't touch the colon. A year later, a scope showed that the colon cancer in the colon disappeared without surgery. So we can treat with one drug 2 types of cancers at the same time. This is the last thing from our patients in Toronto. This is actually a First Nation patient that lives about like a distance between Paris and Budapest. Think about that. So like she lives in an area that there are no roads. So she is a First Nation patient, came after second relapse of glioblastoma, metastatic disease, as you can see. And we started immunotherapy on our protocol, and after 3 months, it actually grew. So this is not flare, this is actually growth. So we sent her home to die, and this is coronavirus time, isn't it? So they go home, and after 3 months or 4 months, we call them, 3 months, we call them and we say, how is the family doing? We thought she's gonna die. This is recurrent 3 of glioblastoma. And she said, she's doing well. So it took us a month to bring her back, and look at the scan that she had in September last year. No tumor. So again, immunotherapy is not chemotherapy. You can have delayed response even after you stop because the immune system starts kicking in. And now it's February. She's still doing fantastically well, as you understand how difficult it is to bring her here to immunotherapy during coronavirus. So again, tip of the iceberg, isn't it? And the last story is our fellow Anirban did something really unique. He looked at medulloblastoma. Remember, this is a tumor that we didn't know it has mismatch repair deficiency, and about 1% of medulloblastomas are actually mismatch repair deficient. Please remember that, because in your country, as Nisreen showed, it can be 20%. You need to do the testing. And this is, again, there's a paper published this week in JCO showing that all patients with medulloblastoma at relapse will die eventually, some slower, some faster. These are 2 patients who recurred, failed therapy at recurrence, and you see metastatic relapse here disappearing, and this patient here and here, brain and spine, lesion disappearing. This is real work of immunotherapy. So, more tumors that we were not aware of, please remember. Last and not least, this is the guy who invented immunotherapy, Professor Allison, wrote this review paper. He says, okay, chemotherapy usually doesn't work. Targeted therapy works a little bit, but not that well. If we believe immunotherapy work, maybe if we combine immunotherapy and targeted therapy, we can get to even better survival. So this is what we did. And then it needs the sequencing that we do. So this needs to be sent here. So we thought maybe most of the tumors will have mutations in the RAS-MAP kinase pathway, which we have pills that we can give with immunotherapy. And when we did that, doesn't work. Okay, this is our tumors. You can see that each tumor had mutations in at least one of the genes in the RAS-MAP kinase. This is tumor 1, 6 mutations. This is another tumor, 5 mutations. So we know that these tumors now are addicted to the RAS-MAP kinase pathway. As you can see, they have extremely high activation of the pathway by RNA-seq. But this is a simple assay comparing them to patients with BRAF fusion, BRAF mutations, and NF1. And you can see that our tumors have higher activation of the pathway, suggesting that they may respond to MEK inhibitors. And I'll jump through that very fast because I want to get to discussion. But you can see that we used our animal models, and we can see that they respond really well to trametinib and selumetinib. And then we treated 2 patients. We actually treated 4 by now. And this is a patient who failed temozolomide because they didn't know it's mismatch repair. When we found it's mismatch repair, it was metastatic. They gave nivolumab, which is immunotherapy, and the tumor grew on that. And then they added trametinib, and look how the metastatic lesions disappear. So again, we already have the 2nd generation of combinations in case we are well diagnosing them, awareness and therapies. And this is the last patient, again, a Palestinian child that had metastatic colon cancer, started nivolumab. This is 5 years from now, and he's still doing well, living normal life. I'm very happy to talk, to have this patient actually know the family. So summarize, guys, awareness, 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 and persistence. Don't worry, we can do it together. New diagnostic tools existing, and they can help us in tumors, because not everything is germline, but also in germline. If we diagnose CMRD, we need to implement surveillance protocol, and how to do it, I think Regine can lead us in all countries. And we have encouraging responses to therapies. Some are immune and some are others that we are exploring together. Last but not least, thank you so much for the lab people and all the collaborators around the world. It's really, really important. And of course, the people who worked in that workshop that Regine leads, the low middle income country. There's a paper from all the geneticists talking about new guidelines. There's a paper about immunotherapy. These people are working together, and it's a fantastic group. And really thank you, many of you who are part of the consortium. It's 173 physicians, and it's growing. Family members. Yesterday, I had a talk with a beautiful family from southern US that asked me, okay, we gave immunotherapy for our daughter, which is now 14, 3 years ago. Should we stop therapy? So we don't have an answer, isn't it? So 4 years ago, we thought there's no hope for these children. Now we have many children. We ask, can we stop therapy? So thank you all. Thank the collaborations, and let's do it together. And I'll stop sharing.
Dear Dr. Uri Tabori, thank you for this excellent talk. It's really very, very important to increase the awareness and to know about all this new knowledge. Now, the floor is open for question and answers and comments. You can put that in the chat, our dear friends. Meanwhile, your mentor, our mentor, Eric Buffet, is also with us. I saw him. Maybe he would like to have, in the meantime, that we have any questions. Will he like to have do any comments? Dr. Eric Buffet? Yes, welcome. We cannot hear you. We can still not hear you.
Can I ask a question?
Yes. Eric, can we hear you once more?
Regine, can I ask a question?
Eric, until we connect you, Professor Faruk Aykan wants to ask a question. A minute, please. Yes.
Okay,
yes,
thank you.
Professor Aykan.
Thank you so much, Dr. Tabori, for this excellent presentation. My question is about chemotherapy resistance in microsatellite unstable patients. Is there any explanation now?
Yes, so this is very important. Thank you for raising this question. So again, as I explained, we have to stop calling them. I know the adults call them microsatellite unstable, but it's not true. They are mismatch repair deficient, because the tool that you guys are using, everybody is using, the 5-promega or the NIH microsatellites are not working. So they are mismatch repair deficient. They can be called not microsatellite and still be very, very sensitive. But the mismatch repair deficiency is necessary for response to some chemotherapy. I'll give you 2 examples. One is temozolomide. So it's a very common drug in gliomas. Temozolomide create mutations which are adduct, which can't be repaired during replication. So that is sensed by the mismatch repair system. They're trying to repair that and can't repair it because it's adduct. And then the cell dies. So if you don't have mutation, if you don't have mismatch repair, which is working, what happens is like giving water. So what happens, it's actually like giving oil to the fire, because actually it creates more and more mutations, and the cells just run through that and are very happy. So actually that's a very common cause of hypermutation in adults, is post-temozolomide mismatch repair deficiency. The second type of drugs is very sadly mercaptopurines, because we use them in leukemias, isn't it? And that's a big problem, because mismatch repair deficient patients do have worse outcome on the BFM type protocols for which have like 2-3 years of maintenance with 6MP. So these, at least these 2, and there are several others, but it actually is a reason to be very careful when you give chemotherapy. For brain tumors, we have a specific protocol that not giving temozolomide. Maybe Eric wants to comment on that. Eric, can we hear you now? Now
do you hear me now?
Yeah.
Okay, so no, thank you very much, Uri. It's always fascinating to hear you. It's so, fantastic. You are so enthusiastic. Thank you again. Yes, so first is certainly a talk that has a much bigger impact in your region than it has in a Western country because of the high level of consanguinity that you see. And it's clear that we are doing everything we can to develop a partnership and to try to introduce immune checkpoint inhibitor in the Middle East. And we hope that it's going to be successful. In the meantime, it's really intriguing to see that since we have abandoned temozolomide and use CCNU for our patients with either Lynch syndrome or mismatch repair, we are seeing a sustained remission in this population. And personally, I'm just blown away with what we see. We have kids who are now 2 years out without any recurrence, who were treated simply with radiotherapy and CCNU. And I don't know whether it's just related to their tumor or whether it's related to our approach, but it's clear that you have to drop temozolomide and to use CCNU instead. We know that there is a cost with CCNU because in some countries it's very expensive, but really the use of nitroglycerin has made a big difference in our practice.
Thank you so much, Dr. Buffet. It's a pleasure to have you with us. And I would like to announce that Dr. Eric Buffet will be our guest on the 17th of February. Thank you from now. Thank you for being with us also. So Professor Aykan he asked the question. He is an expert in gastrointestinal cancers in medical oncology in our institute. And that was a very good question. And I have seen one more question. The question was that, are we causing mismatch by giving alkylating agents? Are we damaging the DNA, right?
That's
that
a very
was one
good
of the
question.
questions.
And just for Professor Aykan, before, I think, as you know, immunotherapy becomes first-line therapy for mismatch repair deficient tumors. So I suggest that all the gastrointestinal patients that you guys have, which are less than 40, should be screened really heavily, and don't use the microsatellite tool, use the immunostain and our tools. We are happy to help, because I think we may be able not to give them chemotherapy. And FOLFOX is, as you know, has an issue, and I'm not going to talk because you know more about that. It's the same idea, that 5FU may not be as sensitive. Just for the story of secondary mismatch repair due to chemotherapy. So for temozolomide, it's very clear that most of the adult tumors who are hypermutant, when you do it at relapse, have this temozolomide-induced hypermutation, which is due to secondary mismatch repair. So the cells see temozolomide. The ones who survive usually get mismatch repair deficiency, usually mutation in MSH6, but it doesn't matter. And then they proliferate, but they have the signature, I told you about these signatures of temozolomide that you can easily detect. Interestingly, not all of them respond to immunotherapy, and we think we know why. But I think absolutely in the future, I hope that we will be able to tailor some chemotherapies and to avoid them, as Eric suggested. We still need to learn more, but we don't sequence tumors at relapse, so that's another story. But yes, chemotherapy can result in second mismatch repair. It's actually the most common cause in cancer. If genetics is 5 to 10%, in adults it's 20%, and the 10% are actually treatment related.
That question also, the same, Dr. Genç also has asked, do you recommend upfront immunotherapy instead of standard therapies in case of MMRD diagnosis? For example, in a child with mismatch repair deficiency and medulloblastoma, do you proceed with conventional chemo after radiotherapy or immune checkpoint inhibitors? That question was related with the DNA mismatch, causing DNA mismatch by the giving alkylating agents. But just to emphasize again, yeah.
So I think that's an excellent question, and we should be very humble and very careful and do what Eric is suggesting, which we are doing together. We're doing a clinical trial, isn't it? Because we are treating together. And I'll explain. Eric has a prospective clinical trial supported by a drug company that is finished now with 10 patients, while we have 80 patients that we treat together around the world, which we get way more information. So the way we should work is together on that. I'm saying that because the answer to the question is not simple. I do think it depends on the tumor type. For example, it may be that for completely resected glioblastoma, the best therapy should be surgery, focal radiation, and CCNU, and then you avoid immunotherapy, which has side effects. And the ones who are relapsed, you can save 30% of these. For other tumors, metastatic colon cancer, and Professor Aikan knows it better than me, there is no cure with the current chemotherapies. So these patients, which respond in 90% in our cohort, it's amazing. I would argue for upfront. Leukemia, lymphoma, we are actually summarizing a very large cohort with the European consortium. I don't have the clear answer, but I do think that patient by patient, I would not start immunotherapy unless you have to. We have a patient now that had fungal infection, could not get chemotherapy, so they are starting. I would give the protocol that you guys have, and also bone marrow transplant. Remember, it's an option. So it's each tumor is different, but we must do it together, because if we have 20 patients that we gave this, we know it doesn't work, and it works both ways.
Thank you. And I would like to remind our participants and colleagues of the, thanks to Dr. Uri and Dr. Tabori and Dr. Eric Buffet, the paper that we have written together with my colleagues in low and middle income countries. Dr. Nesin Amiri is here, Jamila Al-Hutsi is here. We have written the paper which was published in Pediatric Blood and Cancer for the recommendations for mismatch repair deficiency, recommendations for diagnosis and treatment. I will send it to the people who are registered, in fact. It may help in the guidance for the diagnosis and treatment. There are two more questions. One question is that have you used the combination of PARP inhibitors and immune checkpoint inhibitors yet?
Fantastic question. So PARP inhibitors are very interesting because it's called synthetic lethality. You know that the mismatch repair doesn't work, and PARP work on homologous recombination, the Fanconi. Can we work together? So we don't want to do it without evidence. We don't have the signature, again, as I explained, of the homologous recombination suggesting of PARP inhibition in our tumors. But what we do now, we have animal models, so we're doing combinations, and PARP is one of them. But I wouldn't go to humans before you test it on a mouse unless it really makes sense, such as, I showed that with the MEK inhibitors, it has to have scientific rationale, because then you just throw the kitchen sink at them. So the answer is not yet, and I don't know if it's going to work. We can't hear you, Regine. You're muted.
Sorry, yeah. We have another question. Can you give details about MS sign detection systems? Thank you very much, from Dr. Gürses.
Yes, so the old MSI system that many people use in the pathology lab doesn't work, as I explained. It works only on colon cancers in older people, and we know why now. But for younger patients and non-colon cancer, it doesn't work. So if you have a patient or a tumor that you are suspicious of being mismatch repair deficiency, the best screening tool, and it becomes guidelines actually, is immunohistochemistry. And if you have any question, I would suggest to send to us. From several countries, we can do it for free. And from others, it's actually quite cheap. We are trying to set it up as a clinical service. We are also working in another lab in Europe who does a similar assay. So again, it needs to be proven to be clinical, although we already screened 500 tumors in germline. That's for tumors. For germline, if you have a questionable CMRD, our tool is so good that I would suggest just to call us and we can do it for you.
One more question that you had already mentioned, but it is good to emphasize. How long do we have to continue the immune therapies?
So at 4 p.m. today, this is so cool. So guys, we don't know what we don't know. It's always like that, isn't it? And we are struggling. And we have a meeting today at 4 with all the neuro-oncologists at SickKids, because we have one patient who is now finishing Eric's protocol, and we feel awkward, isn't it? So we have patients who stopped and are doing well. We also have patients, as I explained, who stopped and had another cancer after 1 year. So I think the only thing I can say to you guys is that we are blessed to get to this question, isn't it? Because again, 4 years ago, we didn't think this is going to work. And now we have sustained responses. And I don't know, maybe Eric, you can say a little bit about that, because it's also emotional, isn't it? These are precious patients when they're alive.
Yeah, so clearly we don't have the answer. So what we have seen is the first patient we treated, one of the patients published in the JCO paper, discontinued immune checkpoint inhibitor after 2.5 years, and unfortunately developed a brainstem tumor. And this brainstem tumor unfortunately killed him. So we learned first from this negative experience that when your treatment is successful, it doesn't mean that the success is a success forever. So we are a bit careful with this. And it's really something that needs to be looked at according to what you treat. Perhaps it may be easier in colon cancer, where there are a lot of data on these patients from the Lynch experience and evidence that this patient can be cured. But in brain tumors, we have absolutely no data. And the patient that Uri mentioned, our patient who is reaching 2 years of treatment, initially had a glioblastoma of the pinal region. So it was a localized disease. We treated him, and eventually he progressed, but he progressed with diffuse disseminated disease, including CSF involvement. Now, what do you do if this patient is alive 2 years after? Do you say, oh, you are cured, you can stop treatment? The patient, even the family, don't want to believe this. They say, this treatment saved the life of our child. We want to continue it. So, and you have to balance this with the side effect and the risk of the medication. So we are here and we have to learn, and we have to take some risk now. And that's the topic of our discussion today. It may not be sorted in 1 hour, so we will need certainly more time.
Before we end, would you like to emphasize again the diagnosis on which it will be good for the countries where there is a lot of consanguinity to test for MMRD patients? It will be good if we test in all, but the resources may be some limited. But if there's consanguinity, that's very important. But sometimes, even if they don't have consanguinity, they are from the same village and so on. Which tumors should be especially searched for MMRD? I think that will be a good summary here.
Yeah, so thank you. This is still an ongoing story. So again, we're all physicians that learned many years ago, and we still have it in our brain that to do genetics, you take history and all of that. But actually it failed, isn't it? Many of the patients, we diagnose the syndrome from the tumor. Remember the yin and yang. So of course, if you have a good geneticist that has a family and he takes the history and he sees cafe au lait spots and other things, there are some signs in imaging that you can do, then it's good to do the genetic testing. But let's be honest, we miss most of these. But if you have a patient with a tumor, and as I said, it can be a Wilms tumor, that then you take the family history. So One is cafe au lait spot. Second is consanguinity. Third, by imaging and by looking at the tumor, it looks different, and you need your pathologist to be aware. For example, there is very atypical cells. The cells are unhappy. They look giant and multinucleated. Then the Wilms looks different. The glioblastoma looks different. Then you do the reverse genetics. And I think what the guidelines, which are going to be very soon in the WHO book, is that all gliomas, for example, less than 40, should be having the mismatch repair 4-gene immunostain. It's cheap and robust. What I would suggest for now, that if these are not diagnostic or you can't do it, the next level should be central. So either something that through Eurogene or in your area, you have this committee, and it can be very rapidly. And in Europe, I told you there are some, but what we do is part of our job is to answer all these questions. So if you have a patient or a tumor that you're worried, in many cases, you send us the block with history, and then we will decide whether to do the full genetic testing or some. And this has been very, very helpful. Of course, the problem after that, Regine, is let's say you identify a CMRD. That means by definition that the two parents are Lynch, and we need to screen the rest of the family. That's why the tools that we are developing now are so important. And if they become clinical, it will be cheap enough, hopefully, to either get by foundations money or even to implement it in your country.
Thank you. Other than the high-grade gliomas, we had we had also emphasized for the T-cell lymphomas, leukemias, that it may be also, there has been consanguineous in some families where there was consanguinity and MMRD was developed. So for our friends, the hematologists that are with us, right?
I would say more than that. It's actually Hodgkin and B-cell leukemia and B-cell lymphomas and Burkitt's. And it's very interesting. The tip of the iceberg is T-cell, I agree, but not only. And I would even argue that what happens is that Lynch is more common than CMRD. So in your country, tumors, lymphoma leukemias, which are resistant to therapy, you need to stain them because they're probably mismatch repair deficiency either by CMRD or by the heterozygous Lynch, and still need to be treated differently. So again, awareness is very important for all hematopoietic malignancies. And of course, GI cancers, as Professor Aykan said, absolutely.
Yeah.
But I would argue sarcomas above age 15 and Wilms tumors and all of these should not be forgotten.
Yeah, so it can be in any kind of tumor, but high-grade gliomas and also leukemia and lymphomas, as you have said, especially if they are resistant, should be searched for MMRDs. Well, this was an excellent talk. I would like to thank all the participants, all the Turkish Pediatric Oncology Group and the Turkish Pediatric Hematology Group societies who have disseminated the announcements, and the Turkish Radiation Oncology Society and the Turkish Medical Oncology Society, who have, as I said, dispersed the announcements, and also to our colleagues all around the world from Asia, Middle East, Austria, Greece, who are with us today. Thank you for the participation, and we want to thank you, Uri, a lot for this excellent talk and increasing the awareness and our knowledge. And we want to thank Eric also as your mentor, and also for encouraging us doing this kind of work all around the world so that we can collaborate together. I want to applaud you.
Thank you. Thank you very much.
Thank you so much. I will, if you open your cameras, I would like to take the family pictures, my dear friends, so that we can see you all.
Please email us or contact us.
Yes, I will for sure. Zeynep Karakaş, can you open your camera? We cannot see you. I will take a few more pictures. Meanwhile, if you have any questions or comments, you can do so. We have some, I think, had to leave because they have some clinics, but we had over 100 participants from Turkey and all over the world. And really, this is amazing to be. I think these online seminars have worked even better than the congresses because we can connect very easily together. So we want to thank you again, Dr. Uri Tabori, for this excellent talk, and thank you all the participants and for all the comments. Thank you.
Thanks for having us.
Resim mi çekiyoruz? Hepsini şey yapamadık ama. Şu anda yapamayacağım. Niye ses gelmiyor? Ses gelmiyor. Anlamadım.